Hello, welcome. Welcome to the Ontario Network of CAPC and CPNP projects and to our webinar event today. I'm really pleased to have you here so we can learn together about the Health Inequalities Reporting Tool. And my name is Sydney Bell. I'm the the program lead for the Ontario Network of CAPC and CPNP projects. And really just delighted to welcome you all here, those of you who are joining us live and those who are watching this recording afterwards. We'll begin our gathering today by acknowledging the work that we do in communities across Ontario is on Aboriginal land that has been inhabited by Indigenous peoples from the beginning. As settlers, we're grateful for the opportunity to live, work, and play in these places, and we thank all the generations of people who have taken care of this land for thousands of years. This recognition of the contributions and historic importance of Indigenous peoples must also be clearly and overtly connected to our collective commitment to make the promise and the challenge of truth and reconciliation real in our communities, and in particular to bring justice for the murdered and missing Indigenous women and girls across our country. I'll be putting a link to our network's Truth and Reconciliation resource guide in the chat in a few minutes, and I invite you to check it out and welcome suggestions of resources to add to it. So, miigwech, and with that, it's really my pleasure to introduce our speakers today. With us, we have Dr. Gosia Mishkirka. Dr. Mishkirka is a social epidemiologist who leads a multidisciplinary team of experts within the Health Equity Policing Division of the Public Health Agency of Canada. She's also a clinical assistant professor within the Social and Preventative Medicine Department at the University of Montreal. She joined FAC in 2009 and is currently advancing a collaborative pan-Canadian initiative on measuring and monitoring health and social determinants of health inequalities. The work she oversees focuses on monitoring health and social, got a little lost there. The work she oversees focuses extensively on monitoring and reporting on social, environmental, and structural factors influencing health outcomes through a publicly available pan-Canadian health inequalities data tool that facilitates internal and public access to insights on the social distribution of health inequalities and their key drivers at the population level. Another part of this project focuses on advanced quantitative and qualitative research on priority health equity issues, aiming at strengthened understanding of the root causes of health inequities and identifying effective policy and program interventions for multi-sectoral action to improve health equity. Also with us is Shermeen Farooqi. Shermeen is Shermeen is oh my goodness, I'm tripping over my tongue this morning. She's an analyst at the Public Health Agency of Canada. Shermeen is currently a knowledge mobilization lead for the Equity Analysis and Policy Research Team within the Public Health Agency of Canada. Shermeen supports knowledge mobilization activities for the Health Inequalities Reporting Initiative. As a public health practitioner, Shermeen is committed to working alongside others to advance the health of vulnerable populations across Canada through research, evaluation, and data analysis. Shermeen holds a Master's of Public Health from the University of Toronto, as well as an Honours Bachelor of Science from McMaster University. Welcome, Gosia and Shermeen. Wonderful to have you here. Excuse my massacring of a couple of words there. I'm going to pass things over to you. Oh, you're muted, Gosia. Sorry about that. You need to be able to unmute yourself. Are you able to do that? No? Okay. Okay. Okay, you should be able to unmute yourself now.
Yes, I am.
Yay.
Thank
Oh
you.
goodness, hopefully that's all the bips today are mine and the rest is smooth sailing.
That's wonderful. Thank you for this wonderful introduction, Sydney. So again, my name is Gosha Mishkurka, and I'm the manager of the Equity Analysis and Policy Research team. I'm delighted to be here today, first of all, to introduce myself, to show the faces of people who are behind this initiative, and share obviously our insights on the health inequalities monitoring and reporting activities, which are conducted by my team. I'm speaking to you from my place of work in Tiohtià:ke, Montréal, the unceded Indigenous lands of the Kanien'kehá:ka Nation. And in today's presentation, Shermeen will describe the role of the Health Inequalities Reporting Initiative. We call it for short HIRI. And our initiative turned 10 years old last year, and we have achieved many milestones. So we are delighted to share some of our products with you and show how they can be used to inform action on health inequities at the community level in Ontario. So Shermeen will conclude by providing an overview of our key products, and that will include a demo of the health inequality data tool. So we really truly hope that this session would be useful, and we always welcome your feedback. And with this, I will turn to Shermeen. Thank you.
Thank you so much, Gosha, for the introduction, and Sydney for inviting us here. As both have mentioned, my name is Shermeen, and I'm speaking to you from Milton, Ontario. I acknowledge that the land that we gather on is part of the land that I gather on is part of the treaty lands and territory of the Mississaugas of the Credit First Nation. I recognize the traditional territory of the Huron-Wendat and Haudenosaunee people. I also acknowledge the First Nations, Inuit, and Métis people who live on these lands today, and I'm committed to working towards reconciliation. So today's session will be given in English, but I'm happy to take your questions in the official language of your choice. Je me ferai un plaisir de répondre à vos questions dans la langue officielle de votre choix. In the interest of time, I do ask that you please keep your questions to the end of the presentation, but please feel free to populate the chat with your questions throughout the presentation. Today, I will speak to you about the role of our team. Our team, as you know, is called the Equity Analysis and Policy Research Team. And I want to tell you about the history of our initiative. Our initiative is called the Pan-Canadian Health Inequalities Reporting Initiative. I will talk to you about the scope of our inequalities monitoring in Canada, our data and knowledge products, and I will provide a demonstration of the health inequalities data tool at the end of the presentation. So what is the role of the Equity Analysis and Policy Research team? Our role is to lead health inequalities measurement, analysis, and reporting activities under HIRI. This includes a comprehensive approach of extensive engagement with partners and collaborators. Our team maintains and enhances the content of the Health Inequalities Data Tool, which is FACT's primary health equity surveillance platform. We conduct quantitative and qualitative analysis and reporting on priority health equity issues, and we advance evidence on effective interventions to improve health equity. We also engage in capacity building and knowledge translation activities to support uptake and equity-informed data practices. Our work builds on several fundamental domestic and international commitments and calls to action. The WHO landmark report called Closing the Gap in a Generation describes surveillance data as critical for action on the drivers of health inequities. I will also point out the Rio Political Declaration on the Social Determinants of Health, on which Canada is a signatory. Other important commitments and calls for reducing inequities include the United Nations 2030 Agenda for Sustainable Development Goals, and the Truth and Reconciliation Commission, in particular, call to action number 19, which calls on the federal government to, in consultation with Indigenous communities, identify and close gaps in health inequities between Indigenous and non-Indigenous populations and monitor trends in inequities for Indigenous communities. Our project supports sex and gender-based analysis by providing health and social inequity data that can be further disaggregated by sex and gender. And finally, our initiative supports Governments of Canada's Quality of Life Framework, which asks us to look beyond GDP to assess society's progress by including other non-economic factors like health, housing, environment, and safety, and examine the distribution of these outcomes across people. So within the FAC context, we know that health equity data supports the Chief Public Health Officer of Canada's priorities. Our CPHO champions the reduction of health disparities in Canada and has identified health equity as a cross-cutting priority, emphasizing the social determinants of health throughout her annual reports on the state of public health in Canada. So what can we do with health equity data? Here at FAC, monitoring health inequalities has the specific purpose of informing policies, programs, and practices to reduce differences in health that are unfair and unjust. Health inequality data provides a foundation for incorporating equity into evidence-based health planning and also assessing whether current health initiatives promote equity. Our ultimate goal is to inform and mobilize public health action across downstream and upstream health and social determinants of health outcomes to improve population health and to provide evidence for strategic partnerships with other sectors and departments to inform intersectoral action that can improve and advance health equity. So this slide shows you the scope of our work within HEARI, and in particular, the scope of data available within the Health Inequalities Data Tool. We bring together data for more than 180 indicators of health outcomes, such as mortality and life expectancy, morbidity and disability, but also health determinants like physical and social environments, healthcare, etc. And these are systematically disaggregated by a range of social and demographic stratifiers that are meaningful to health equity. And we've listed those here. So they include income, education, employment, Indigenous identity, geography, immigration status, among others. The data tool was first launched in 2017 with intentions to refresh the data every 5 years. And I'd also like to note that in line with an intersectional and SGB approach, you see that we have 3 layers of stratification. So we have the social stratifier itself, we have male-female, and then geography, national or provincial territorial level. And increasingly, as we incorporate additional indicators and update our tool, we now, for some indicators, are able to not only disaggregate by male, female, but also other gender categories. So one of the unique characteristics of this initiative is that it brings together in one tool data from 20 different national data sources. And this was achieved by working closely and collaborating with many data custodians. The data is a mix of administrative data sources such as vital statistics, survey data, including surveys on health behaviors, and census data. We recently added the Canadian Housing Survey. We work with a number of data custodians, primarily with Statistics Canada, but also with other core partners such as CIHI, the Canadian Institute of Health Information, and FNIGC, the First Nations Information Governance Center. We also work with academic partners such as the Afford Center for Child Studies for early child development data, and our own colleagues at FAC for infectious disease and reporting and the health behavior school-age children data. Advancing health equity requires comprehensive approaches that include engaging and collaborating with partners across sectors. Here he brings together data from multiple sources in order to stimulate intersectoral action and dialogue. We work with a broad range of partners and stakeholders, including our core partners, PTs through the Public Health Network, CIHI, Statistics Canada, and the First Nations Information Governance Centre. We have continuous engagement with national Indigenous organizations to ensure our reporting is consistent with Indigenous perspectives on health well-being and health equity. Finally, we also rely on the expertise of our working group members, which include academic and PT subject matter experts, NGOs, federal departments, and agencies whose mandate touches on the social determinants of health. So in order to ensure that the unique priorities, worldviews, and contexts of Indigenous peoples are reflected in all aspects of our work, we follow a distinctions-based reporting as one of our principles. We want to ensure that the unique priorities, worldviews, and circumstances of First Nations, Métis, and Inuit peoples are reflected in all aspects of our work. So this means that elements of analytical plans that are relevant to Indigenous peoples are developed in partnership with Indigenous organizations, and that ongoing guidance, input, and approval from Indigenous partners is incorporated at each step of our product development. Our journey so far has included many achievements, such as the release of our first subset of health inequalities indicators, followed by the launch of the Key Health Inequalities in Canada report. In later years, we focused a lot on enhancing the data tool, publishing a report on COVID-19 mortality inequities, dedicating time to capacity building activities, including a tool for integrating intersectionality theory and quantitative health equity analysis, and a summary of international and domestic efforts to monitor health inequalities through time. So that's the temporal analysis report. Currently, we are working on advancing inequities in mental health and well-being, and we hope to deliver on these findings by the end of the fiscal year. So here's a display of some of our tools and products. The data tool is indicated on the left, and we're going to be doing a demo of the data tool soon. We have indicators, as I mentioned, with federal, provincial, territorial level disaggregated data. It's interactive. We have in the middle our narrative report, Key Health Inequalities in Canada, that focuses on a subset of 22 indicators reflecting the deepest inequities in Canada. And we also have a set of infographics and an animated video for non-technical and lay audiences. So since presenting to this group on the data tool about 5 years ago, we've added a number of indicators to the data tool. And I've listed those here. So in July 2022, we added some indicators for safe and stable housing. So housing need, experiences of homelessness, housing instability. We also added mental health and well-being indicators such as life satisfaction, access to care, in particular healthcare. So having a regular healthcare provider, receiving help for mental health needs. And in 2023, we've added multiple indicators from various data sources. So we have the labor force survey on precarious employment during COVID-19. We have now indicators on oral health from the Health Behavior and School-Age Children survey, and we have some indicators from the Census 2021, such as core housing need. So this shows you some important features of the data tool. Our data tool is publicly accessible. Anyone can access it just by Googling Health Inequalities Data Tool in in any search engine. It's very user-friendly, so it has drop-down menus that allow you to drill down to the data that you want. It's open content, so you can download the charts. You can also download the data if you wish, and I'll show you how to do that in a bit. And all of this allows for better policy and program decisions, because this disaggregated data can help us identify those most affected by health and social issues, and it can help us direct resources to health issues for groups experiencing the most disproportionate risk. Before I jump into the data tool, I just want to sort of show you some of the data that you can pull from the data tool, as well as how to interpret it. So we, in our data tool, have many different measures of inequalities, and one of those measures is called rate ratio, and I'm going to explain how to interpret rate ratio through an example right now. So this was pulled from our data tool, from the latest version of our data tool. And this is children vulnerable in the domain of language and cognitive development, 4 to 6 years old, for Ontario. On the y-axis, we have the rate ratio, which I'll explain what that means in a bit. On the x-axis, we have 5 different income quintiles, from the lowest to the highest. So income quintile is just, you take the income of the population and you divide it into 5 different groups, from the lowest to the highest. And the highest income group is actually the reference group. So in each example that I'm going to show you, there will be a reference group, and the reference group is the group with the highest perceived social advantage. Males are yellow and females are green. And so if we look at Q1, and in particular, look at the data for girls, which is in green, we see that the bar reaches, almost reaches 3. So what this tells us is that the proportion of children who are vulnerable in the domain of language and cognitive development is almost 3, so 2.91 times higher among Ontarian girls in the lowest income quintile compared to the reference group, which is Q5, the highest income quintile. So rate ratio tells you how many times higher the rate is for the group of interest compared to the reference group, which, as I mentioned, is the most privileged group. And you can see that the rate ratio for boys is just a little bit above 2.5. The value for that is 2.62. So also in our data tool, we have absolute measures of inequality available, such as proportion difference, which I'll explain in a bit. So this graph is children vulnerable in at least one domain of early development. So there are many domains of early development. There's physical health and well-being, social competence, emotional maturity, language and cognitive development, communication skills, and general knowledge. But this graph is showing us which children are vulnerable in at least one domain among all the ones that I listed of early development. And this is for children aged 4 to 6 years in Ontario. On the y-axis, we have the proportion. And then on the x-axis, we have the 5 different income quintiles. And looking at the yellow bar, which is for males, we see that it's just higher, that it's just right at 15 there. And so what this tells us is that the proportion of children who are vulnerable in at least one domain of early development is, so actually the value that I have written down is 13.76. So it tells us that it's 13.76 times higher among Ontarian boys in the lowest income quintile compared to boys in the highest income quintile. So we also have measures that illustrate the magnitude of inequality in population terms, such as population impact number. So here we have core housing need. Core housing need is those who reported living in housing that fails to meet at least one of three standards established for housing adequacy, suitability, and affordability, and households that cannot afford alternative local housing. So we see that for the East-Southeast Asian group, that the value is around 128,000. So what this tells us is that if East-South Asian groups had the same core housing need as the reference group, which is white Canadians, there would be 128,928 fewer Ontarians living in core housing need. So this measure is very powerful because it tells us how many cases would be avoided if everything were equal. Okay, so now I'm going to move into a demonstration of the data tool. Okay. So this is the page that you would land on if you were to Google Health Inequalities Data Tool. This tab that I'm currently on hosts the data tool and inequality measures. So I'm just going to click the next tab. So the next tab provides rates of our 177 indicators by provinces and territories. The next tab provides background information on our initiative. And the fourth tab provides information on the 177 indicators themselves. At the top, you can see that we have shown which indicators are available for which life course stage: the general population, infants, adults, and seniors. Scrolling down, you can see more information about each indicator. We try to provide as much information about each indicator itself, including the indicator, life course stage, indicator description, source and year, method of calculation, and the available stratifiers. The 177 indicators are grouped into two domains. So we have health status and health determinants. And I just wanted to go back to these placemats here because they might be very useful, particularly if you're looking for what indicators are available in our data tool. So this is all of the data that we have available for infant, children, youth, and young adults. These are all the available indicators, and you can see the wide breadth of indicators that are available. We have morbidity and disability, mental illness and suicide. Scrolling down, we have health behaviors, social inequities like food insecurity. These are all the early childhood development indicators that we have. We also have many health behaviors. So that might also be of interest to you: playing outdoors, screen time, etc. So I'm just going to go back to this page, which has information about the indicators themselves. So the indicator that we're going to be looking at is later on in the demo is children in low-income families, according to the low-income cutoff. And that's in the social inequities folder. And here, so I'm just going to scroll down to children in low-income families, according to the low-income cutoff. So here we can see that we have the definition: children living in households that fall below the after-tax low-income cutoff, where the data comes from, Census 2021, the numerator and the denominator. And then when I click on details, this tells you all of the different stratifiers that are available for children in low-income families. So we have age group, Indigenous identity, cultural racial background, immigrant status by cultural racial background, education, rural urban geography, first official language spoken, living arrangement, remoteness index, first official language spoken by geography, and geography. Now, the fourth tab that we have here is the Publications tab, and it has other HERE publications that I had mentioned. So we have our Key Health Inequalities report, our report on COVID-19 mortality inequities, and then we also have infographics available from the 2017 edition of the data tool, but also the 2022 edition of the data tool, and this is where our animated video is housed. And these infographics are very plain language, and they distill the evidence in a very easy to understand way. So I'll just briefly show one to you. We've pulled out some of the data from the data tool, some of the rate ratios, etc. So these can be very useful. So now I'm going to go back to the data tool and begin a demonstration. So the example that we're going to look at, as I mentioned, is children in low-income families by cultural racial background. So I'm going to use the 2022 edition of the data tool because it's the latest version of the data tool. It has the most updated data. I'm going to select Ontario, but you can see that we have many different provinces and territories available. They're all here. And then we also have national data along with the PT data, but I'm going to select Ontario. For framework components, I'm going to select social inequities. That's the folder within which children in low-income families is housed. For the indicator, I'm going to choose children in low-income families. There's only one life course stage available, of course, because we're looking at children, but for some of the other indicators, we have multiple age groups that you can select from. For the stratifier, I'm going to select cultural racial background, but just note that we have many other stratifiers available, as I had mentioned, immigrant status, education, etc. I'm going to select the age standardized rate first, but you can see some of the other measures that I had sort of talked about earlier, rate ratio, rate difference, etc. But for now, I'm going to select age standardized rate. And just for ease, I'm going to deselect males and females and just leave both sexes selected. So here you can see how children in low-income families sort of varies by different cultural racial backgrounds. You can see where the highest rates are, where the lowest rates are. And when you hover your mouse above a particular bar, the value pops up. So we can see that the rate of children in low-income families is 12.4% among those of an Arab background, 10.5% for Latin American. For South Asian, it's 4.6%. I'm now going to choose rate ratio, which I had explained earlier. And I'm going to deselect males and females. And so now this is a different measure. So it's rate ratio. And when we hover our mouse above Arab populations as an example, we see that the rate ratio is 4.25. So what this means is that the rate of children in low-income families among Arab Canadians is 4.25 times higher than the reference group, which is white Canadians. And we can see, you know, the rate ratio for different population groups here. South Asian, it's 1.56. Scrolling down, we have all of the values available along with 95% confidence intervals. So confidence interval is if you were to repeat this analysis an infinite number of times, 95% of the time, the value would be between this lower and upper limit. So it tells you how confident you can be in the data that we're providing. We have some notes over here, the source, and then the suggested citation. You can print the chart or save the chart. And you can also download the detailed table or download the summary table, which is this table here. And I just want to do one more example, actually. Maybe one of the examples that we had looked at earlier in my slides. So that one was children vulnerable in the domain of language and cognitive development. Okay, so we're going to look in early childhood development. And we had done children vulnerable in the domain of language and cognitive development. Children. And the stratifier that we chose was income quintiles. And here's the rate ratio. So I'm just showing you how sort of you can pull some of those examples that I had illustrated earlier. And here we see that for females, the rate ratio is close to 3. So the rate of children vulnerable in the domain of language and cognitive development is 3 times higher among girls in the lowest income quintiles compared to the highest. And then if we do children in at least one domain of early development, if you recall that example, I'm just going to deselect both sexes. And then we had done rate difference, if you recall. I'm going to deselect both sexes as I did earlier. Okay, so the rate difference for boys is here around 15.35, and for girls it's 13.76. So this tells us that the proportion of children vulnerable in at least one domain of early development is 15.35 times higher among boys in the lowest income quintile compared to boys in the highest income quintile. And then for girls, it's 13.76 percentage points higher among girls in the lowest income quintile compared to girls in the highest income quintile. And I think there was a slight discrepancy on my slide about that, so I apologize, but these are the correct numbers. So it's 15.35 for boys and then 13.76 for girls. So we try to provide users with as much information as possible. And one of these resources is this document here, which is, it's just a little explainer on what rate ratio is, what rate difference is, what population impact number is, and how to calculate them, what they mean. It's just a little lesson in case you need something to refer to beyond this presentation or after this presentation. And I'm just going to go back to my slides now that we've concluded with the demonstration. Oops. Okay, so in terms of what's coming next for EPR, we are working on new content and updates. We're undertaking analysis to develop a new tab on the menu that would provide the ability to monitor inequities in provinces and territories over time with a decade of data. We'll also be providing a new tab that would host an inventory of equity interventions. And this is work that we will finalize in the next year. And there will also be a final tab where the mental health inequities report will be published along with an accompanying data tool in the next fiscal year. So for more information or questions, you can contact our single window email, which is indicated here. And I'd just like to give Sydney and Blanca a big thank you for organizing this session.
Thank you, Shermeen. Okay, I'll just join you here. Oops, there we go. Thank you, Shermeen. There are a couple of questions in the chat that I'll read out for you, and then we can certainly open things up. I'll shift the settings so folks can unmute themselves or come on camera, or certainly feel free to type more questions in the chat. But the first question we had from Lee was, are ACEs something which may eventually be incorporated as an indicator, or anything that demonstrates or speaks to the experience of trauma at any point of life?
So ACEs, those are adverse childhood
experiences. Yeah.
That's a really good question. We are, as I mentioned, we do often update our data tool, typically every 5 years, sometimes more often than that, but it's typically every 5 years that we update with new indicators, and we are always thinking about new indicators that we can include in the data tool. Maybe what I'll do is I'll actually go to that little information sheet that I had shown earlier to see if there's anything related to ACEs that might be of interest. So
I was trying to spot that too as you were showing it. I do think there is, there were sections on sort of mental well-being and stressors.
Yes, exactly. So that's kind of what I was thinking about in terms of anything that might be related to ACEs. But I mean, we do have a lot of mental illness related indicators. And then scrolling down here, we have family support, friend support, sense of community belonging. Let's see here. Scrolling down, we do have those early childhood development pieces. So I mean, let's see what else. Healthcare. Oh, Gosha. We have some perceived need met for mental health problems. I'm trying to see if there's anything else related to ACEs, but
well,
I mean,
I'm not sure if there's a like a tool or a framework out there that's sort of recording the data under that framework
of adverse childhood experiences.
Can I jump in? Because I think this is an excellent question, and it's not the first time that we hearing the need to provide more information about early childhood development and experience of adverse circumstances. And many of those discussions kind of ended up by asking for a lot of caution if we are going to do so, especially because we disaggregate that data by race, ethnicity, or income, and that could be very stigmatizing if it's left on a data tool without a proper way of indicating how to actually interpret those measures. So I recall those conversations. I think we might want to need to, because I understand the need, and it's not the first time we're hearing this, but I think it calls for a group of experts and a broad discussion with communities as well, how to do it well. Because the same questions came about family violence and should we report and leave the data on family violence groups by race, ethnicity, for example, out there. So I think it's with the caution, but I think there are possibilities to access that data. There are some good measures. It's just a matter of being really doing this in a meaningful way and just making sure that we don't stigmatize or increase misunderstanding or misleading the audience. So thank you for that question, because it was in the back of our minds many times, and it's potentially something that we need to bring back to our working group and see how we engage with communities as well about those, very, very much sensitive measures that exist. Thank you.
Thank you. There's another question around the reference range. So the question is white Canadian chosen as the reference range only when it is the lowest of the subpopulations identified, or is it always the reference range rate, as it is possible that another subgroup could have a reference range RR less than 1? I hope I've expressed that.
Yes. That's a good question. Maybe I'll start, and Gosha, you can jump in, but so when we are disaggregating by cultural racial background, the reference group is always, and this goes for any stratifier, the group with the highest perceived social advantage. So white is typically the reference group that is used. Now, sometimes what we see is that, in fact, there are inequities where white populations may, their rate may actually be higher. So for some of the, I believe the alcohol-related indicators, you'll see that, in fact, it's the white populations that have higher rates. And maybe Gosha, you can jump in.
Yeah, so yes, you're right. We conceptualize white population as being conceptually the most socially and materially privileged conceptually, but there are many indicators. So when we run analysis, we set white population as being the reference group. But our measures are able to capture whether they doing poorly in some health outcomes or behaviors or social determinants of health, and we can see variation, also variations in different jurisdictions. So it's good to set that equally to all indicators, because it's easier also to see how that is different for different outcomes and different geographies. So very useful, and measures are able to capture when they're doing poorly compared to the groups to which we compared them. So I see where the question is coming from, because sometimes we could select maybe different groups, but this is done systematically for a large number of indicators. So hopefully that's useful. And when it comes to other indicators like education or income, yes, the reference group will be always the group that is the richest, or the group that has the highest education level, etc. Thank you.
Okay, thank you very much. If anybody else has a question, feel free to pop it in the chat, or unmute yourself. You're welcome to come on camera as well. One thing I've been sort of wondering and thinking about as I've been listening to Shermeen is like how you might think the tool could be useful, say, for our project staff when we're doing things like say a community needs assessment is something that we've been encouraged to do as we develop our programs, and certainly thinking about, we have a reapplication process coming up in a couple of years. So that it may be too big of a question to answer in the next few minutes, but are there any sort of quick insights or tips that you could provide to us around using the tool to support an undertaking like a community needs assessment?
That's a very good question. My understanding of community needs assessments is typically they're a little bit more localized,
Yeah.
you know, to
Yeah.
specific geography and neighborhood, for instance, or even smaller than that, like a say, I don't know, a little subset of a particular neighborhood within a city. But I think that the tool can be helpful in terms of highlighting where inequities might exist for the population groups that you serve. So for instance, if you know there's a large proportion of, say, a particular cultural racial background in your community, you could look at where inequities exist for that particular group. Mm-hmm. I think that, and then, you know, if there's a specific issue that you're working on, say it's food insecurity, you can see where the deepest inequities exist for that particular indicator. So which population groups are most affected by food insecurity? Right. So you can also look at sort of the inverse. Right. And I mean, as you saw, the data that we have available is, or the lowest geographical level that we have available is PT, so it would be Ontario. But I still think that that data would be helpful in a community needs assessment in terms of maybe setting the stage or providing context before you sort of go into some of those more localized, you know, statistics or information or survey, you know, community surveys that you may have done at the community level for your needs assessment, or any studies that you may have done, you know, with the community. I think that it can help provide sort of that opening, you know, that introduction in a needs assessment or reapplications. And I know that when I last presented to this group, someone had mentioned that they had used some of the data from the data tool for a funding proposal. That's one way that we've heard that the data is being utilized and the way that it's been helpful. So that's just one sort of suggestion.
You had also mentioned, I think, making community connections or partnerships in your introduction, that it might be beneficial there as well.
Mm-hmm. Yeah, so I did mention in my presentation how it can inform intersectoral partnerships because, yes, so because we have many different ways of sort of disaggregating the data, you can see, you know, for a specific indicator, say it's, I don't know, early child development, which we looked at, you can see, okay, this seems to really be affecting people who are low income, you know, compared to high income, and maybe income groups that work or act on income is one group that we should partner with. So that's sort of what we mean by informing, you know, intersectoral partnerships. And I see Gosha has her hand up.
Oh, I didn't want to interrupt, Shermeen, but I think maybe from time to time, community-based organizations are being asked to use SGBA plus approach.
Yes.
I think I've seen this often, and the entire tool is set up to actually allow that, because we, as Shermeen demonstrated, we have all the data whenever it's available and doable. We disaggregate for both sexes, but also boys and girls, men and women, and when the data is available for Ontario, again, to Shermeen's point, to set the tone or to really, you know, point to those inequities by gender, where the needs are in Ontario. It's always a good starter, I think. And also there's a tab that I believe Shermeen showed how Ontario compares to the rest of the provinces sometimes could be a powerful tone setting. Sometimes delicate, but sometimes powerful.
So the SGBA plus, that's the sex and gender-based analysis that
That's
we're,
right.
yeah.
That's right.
Yeah.
So we if you think about early childhood development by income for boys and girls, you have the SGBA plus applied here because it's gender and income in the same chart. You have data there, and you can start with this, right?
Great.
Yes, because I know that sometimes community organizations are asked to provide SGBA related information or data on funding applications, and it can be so the tool can be very helpful in that regard.
Okay. Thank you for that information. I'm not seeing any other questions in the chat or any other hands up. So I think we might be coming to the end of our session. Just doing one more little quick pause to see if anybody else has a question. Jen posted in the chat, what does SGBA stand for? And that's sex and gender based analysis, if I've got that right. So thanks for asking that, Jen. And well, I guess that brings us to the end of our time together. Thank you so much, Shermeen and Gosia, for your time and giving us a review and a tour of this tool, which I think is a very helpful resource for us in our work. And lots of gratitude coming in the chat for you and for the information. And thank you for your time, and wishing you all a wonderful rest of the day. And we have made a recording of this session, so that will be sent out in the newsletter and to everybody who registered, and also on WebConnects. So that'll be another resource. We can come back and give it another listen. Thank you again, Shermeen and Gosia, and I hope our paths cross again.
Thank you.
Thank you for the invitation. Bye, everyone. Good afternoon.
Bye-bye.